Ladies and gentlemen, help me welcome Dr. Today, as a I want to say and the focus of this presentation is management applications and also how
the audio needs this audio. I can go on.
sorry for the so my presentation will follow this outline. We look at the cases and how they were managed, and then we'll go through the literary review and how what lessons were learned from the cases. So the first thing was of a 15-year-old male who was doing hypertension in diabetes. And he presented to the polyclinic in Accra with sudden onset of pain in his left leg of an hour duration. And I'd like us to take a look at the time durations. So at that polyclinic, he was kept on admission and started on IV analgesia and antibiotics on account of the suspicion of cellulitis. After 7 hours, there was no improvement in his condition and further care, which was when we saw him. And when we did, general examination was unremarkable, but the patient was in obvious pain. His cardiovascular examination was also unremarkable, except his blood pressure, which was 156 on 100 and his speed. Focus on the status of Alice revealed a cyanotic distal tear of his left leg was fully touched. There was no capillary refill. There was complete loss of sensation in the right section of this affected. And on palpation of the artery stair, popliteal posterior tibialis and the locality feeding forces were all doing bad. There was lack of mobility of the vein, i.e., the patient could not wriggle the toes. There was no infection or plantar flexion. There was no pedal edema obstruction in these groups. And the other thing we looked at for were the world's greatest probability score for the was low, which meant that it was not likely. And the central nervous system, respiratory, and gastrointestinal were all unremarkable. So at that point, an impression initially of the peripheral arterial disease and the query of acute limb ischemia was made. The patient was started on IV anticoagulation with unfractionated heparin, 7,500 units national unit start, and then to continue with 5,000 national units 8 hourly, and analgesia with IV paracetamol 1 gram also started. An arterial Doppler ultrasound, at this point, the medical surgeons are ready to inform about this case. An arterial Doppler ultrasound has been requested, and it took, by the time the Doppler ultrasound was done, the patient's symptoms had lasted 13 hours, which is another long delay. And the Doppler showed a total occlusion of the left superficial femoral artery, the popliteal, the anterior and posterior tibialis arteries were all occluded. The left dorsalis pedis artery was also occluded, and there were no pulsations. And a bit higher up, the common femoral artery was about 80% occluded. There were other investigations that had been requested. Subsequently, the medical review told me that by the ECG and ECHO were suggestive of a hypertensive heart disease. The sugars were poorly controlled, as you can see in the HbA1c. COVID-19 PCR was negative, and renal function was unremarkable. At that point, the diagnosis, and based on the clinical findings and the arterial Doppler, the diagnosis of a non-viable left limb secondary to an acute limb ischemia was made, and the patient was counseled for amputation. The intraoperative findings were unremarkable. Post-op periods, post-op day 1 and post-op day 2 were unremarkable. Unfortunately, on the dawn of the post-op day 3, the patient went into shock, and there were several attempts to resuscitate this patient, including trying to get it from ICU, all of which were unsuccessful. Unfortunately, the patient passed away in August, then the cause of death as a massive pulmonary embolism. For the case 2, we had a 56-year-old male with a 10-pack-year history of serious smoking. He had presented with a 4-day history of sudden onset pain in the right leg, which was worse in the calf. The pain had lasted about 4 days before he presented to hospital. And the first hospital he presented to was put on oral rivaroxaban and oral atorvastatin, and then asked for an arterial Doppler ultrasound scan for further evaluation. It took a better 3 days for the scan. Another delay. So he did a scan and brought it to us at the clinic. He looked generally well. He was not ill. He was not running or febrile. Not an obvious pain. His random sugar was normal. Cardiovascular examination once again. Examination, the status localis showed that the right lower leg was slightly swollen and not gangrenous, but also that tenderness along the calf. Sensation was intact from the knee down to the medial mandibular, but this study it was absent, and the right femoral pulse was intact, but the popliteal, posterior tibialis, and were not palpable. The other systemic examinations were unremarkable. The arterial Doppler ultrasound scan that he brought showed a complete occlusion of the right popliteal artery. So at that point, the diagnosis of an acute limb ischemia of the right leg. For this patient, once again, the vascular surgeons were involved, and there was, I must say, a spirited attempt to try and salvage the limb. And there was coordination with some facilities around Accra, the table, angiogram done, and there was an attempt at lumbar embolectomy, all of which were not successful. And so the patients had an above knee amputation performed. Fortunately for us, the post-operative period had been uneventful. So in these cases, I'll just do a very quick review on acute limb ischemia. As we know, it is the sudden interaction of arterial blood with limb that threatens the limb. And it can occur in all limbs, but more especially in the lower limbs. The global incidence is about 1.5 per 10,000 persons, and we know peripheral arterial disease is a significant modifiable risk factor for acute limb ischemias. And the global incidence for peripheral arterial disease is about 200 million. There are two main mechanisms by which acute limb ischemias occur. We have the involved embolization and the prophylaxis. Less commonly, you could have trauma, which may be iatrogenic or non-iatrogenic. So, for example, if somebody did an intra-arterial cannulation or some of the procedures, it would cause that, or if somebody has non-iatrogenic trauma from a fracture or start with arterial deformity, it could also cause that. But the two main mechanisms I'll focus on in this presentation are the embolization and the thrombosis. And I want to focus on that because which phenomenon occurs, whether it's an embolus or a thrombus, actually determines how the patient will present and how the patient ought to be managed. So in embolization, you have an embolus that originates from one side and travels to a distal site, and this may be cardiac or non-cardiac. 85% is cardiac, usually from cardiac. So in your assessment of these patients, these are some of the things that you want to look out for. So atrial fibrillation or post-MI neural thrombus, or it could be a debris from a disease alpha or very rarely atrial lymphoma. You could also have a phenomenon called paradoxical embolization, where you have an intracardiac death through which a blood passes and enters systemic circulation, and that may occur in patients with a patent remnant valley or a sometimes even in atrial septal defects. In 50% of cases, you have a non-cardiac origin. Then, with the thrombosis, you may have a bromide formed on an ulcerated atherosclerotic. Now, when somebody has an embolic phenomenon, because they have a previously healthy vessel, and then an embolus suddenly occludes the affected vessel, their symptoms tend to be very dramatic. So these patients present with very sudden onset of pain. These patients typically would not have been well, they wouldn't have had issues previously. So the symptoms occur very suddenly. The other thing that you want to know is once the patient has grown an embolus in one particular bed, they are at risk of growing emboli in other particular beds. And you have to, in your assessment, look for some of these emboli. So I've been wondering, even with the first things, I've wondered myself, was the pulmonary embolism part of the overall disease process the patient was having, or was it purely a post-operative issue? So that's something that you need to look out for. Also, patients who have emboli usually will have total occlusion of the affected heart compared with the thrombus. Now, in the thrombus, you have a vessel that is already diseased, some form of atherosclerosis ongoing. So this patient will have been having some medication or something on and off over the period. And it goes on for a long time. So it's usually not very dramatic because there's a lot of time for the vasculature to mobilize to that place. And until the day when there is an acute exacerbation of what has been ongoing for some time. And so in the history taking, these are some of the things that the family physician have to look out for. In terms of the risk factors, these are generally risk factors for a lot of cardio atherosclerotic cardiovascular diseases that know with the modifiable and non-modifiable risk factors. In 2017, we did a study where they found out that 71% of patients who had been put for amputations had peripheral arterial disease for various degrees, and of these, 57.3% of them had hypertension, 70% had diabetes, and 9.7% were hyperlipidemia. Permit me to talk briefly about COVID-19. As you saw in the first stage, we requested for a COVID-19 PCR for that patient. We know that quite a number of the respiratory viruses, including SARS-CoV-2, SARS-CoV-1, and even the MERS-CoV viruses, have documented pulmonary complications. And in COVID, at the peak of COVID-19 in the US, the incidence of acute limb ischemia in patients with COVID-19 was up to 21 per 100,000 hospitalized COVID-19 patients. The majority of these patients were at the age of 60 and had other cardiovascular comorbidities. I also have to mention that majority of these cases occur in persons with severe disease, even though we see some of these cases in mild to moderate disease. Very, very rarely, some of these occur in persons who do not have respiratory symptoms. So the limb ischemia or the presenting symptoms of the patients. In your examination, you want to do a very thorough general examination or systemic examination with particular focus on the cardiovascular system. And here I want to emphasize that the cardiovascular system is not just the heart, but with the heart in the vessel. So you have to examine the arteries very, very carefully. So starting locally, you'll be looking out for what typically called the 6 P's of acute limb ischemia. So the pain, the pallor, the pulses, the polycythemia, the paralysis, and the paralysis. Anticoagulation index is if you have a handheld Doppler in your consulting as a family physician, you can determine the anticoagulation index, which will give you an idea of the degree of arterial occlusion that the patient may have. I'll just use this slide to conclude. So when you have a patient, what can a family physician do? You have a patient who has signs and symptoms of acute limb ischemia. Remember that time is of the essence. You don't want to lose the limb, you don't want to lose the life. And so your investigations must not delay your interventions. So once you diagnose that this patient, and with a very good history and physical examination, you can diagnose acute limb ischemia even before your imaging studies. So you want to start with, if there are no absolute contraindications, you want to start with anticoagulating the patient as quickly as possible. If you're able to do this within the first month, you can actually achieve reperfusion rates of up to 60% immediate, and 2-year maintenance of patency will be as high as 80%. Then you want to do what is known as the Rutherford classification. Now, I'm running out of time, but what the Rutherford classification does is that it shows you the degree of arterial occlusion, and then it also tells you how viable the limb is and how salvageable that limb is. Now, because time is of the essence, when you have Rutherford 1, it's a viable limb. So you can have some time to do a lot of your angiographies if they are available for you. In Rutherford 2, the limb is marginally threatened. It's salvageable if you treat, 2A. It's salvageable if you treat quickly. Again, there may be some time, but when you move to Rutherford 2B, where the limb is immediately threatened, you need to weigh the benefits with the risk. Doppler ultrasounds are quite easy to do and available in a lot of primary care settings, but angiography may take a bit of time, and so it should not delay your intervention and referral to a vascular surgeon. So, Rutherford 1, 2A, 2B can salvage Rutherford 3, then you have to amputate this patient. So, in conclusion, the lesson that I learned from these cases is that in both of them there were significant delays. For the first case, in the initial presentation, acute limb ischemia did not even come out at the initial facility where the patient presented the whole 7 hours for the patient to present subsequently. In a study done at the Agapan University Hospital, Brian found out that when they looked at 55% patients that had presented to them with limb ischemias, the major reason why the patients had presented late was because of non-referral by the primary care physicians. And the major reason for that was because the primary care physicians had not recognized the signs and symptoms of acute limb ischemia that the patients had presented with. So these are the rules that we expect the family physician to perform in this case, recognizing the condition and recognizing that the vascular emergency and time is of the essence. We need to intervene and repair the patient very, very quickly. These are my acknowledgements. Thank you very much.
Thank you very much for your time. When is that time? If you intervene and on time. Thank you very much once again. And sorry for rushing you, but I think that time, Dr. Good committed is 10 minutes. It was 10 minutes. When it's 10 minutes, it's 10 minutes. Thank you very much. Next, we tend to ask a very good friend of mine, so she left. Okay. So a lot of us know her. She is a senior family physician, fellow of the Ghana College of Surgery. Currently, she's by the base at the Clark Hospital. where is the clinician with the public health department, helping them to start training. One of the areas of interest is diabetes, and as you get more, find also how to manage a lot of program management. Ladies and gentlemen, doctor who are at your left. I think it's very good. I think I'm ready. They know what to do and what to do. Thank you.
Very good news to you.
Yes.
Yeah. The public position. And telephone. Thank you so much for being. Technology. Technology is good if it works. So I think my laptop. Right. So I'd like you to join me in this presentation as much as you can. I'll be asking questions. So I won't follow you. But I'd like you to join. Right. So I'd like you to think about the past 6 months and your facility. And I'm wondering how often you made it, like you saw patients you suspected of having pulmonary embolism. And how often did you have to look out for or search through history physical examination? And how often do you use the risk stratification score? Well, with quite a time. And then how often did you make a definitive diagnosis of pulmonary embolism? So I wanted to be as interactive as possible, but I think you'd require internet data to do this. So unfortunately, I can't do the code, but still as interactive as possible. So, and if you know me, I write. I do poetry. I'm trying to write something. Who am I? I'm often misdiagnosed, underdiagnosed, delayed diagnosis. I'm always selecting. Look behind you, and I'm there beside you, right here. In the shadows, quite near. If you research for me, just my timing, very good, right there. So my name is mentioned. I went to the site again. Right. presenting on anticoagulation in venous thromboembolism. And what we'll be doing is to do the diagnosis of enhancement and have an overview of anticoagulation venous thromboembolism. So my outline is, so what is venous thromboembolism? So a thrombus is just a fibrin and clot, and the fibrin, a lump of fibrin and platelets in the vascular lumen. And when it's moved from one location to another, it's called an embolism. So a pulmonary embolism can be of any material. It can be a thromboembolism, or it can be fat or amniotic fluid, depending on where. So remember our record trial. Remember what usually we call venous thromboembolism. Venous is the type of thromboembolism. Venous thromboembolism is a spectrum. So the most common diagnosis or the most common conditions are either a deep vein thrombosis or a pulmonary embolism. But there can also be an upper extremity DVT, an upper extremity deep vein thrombosis, which can also embolise. But these are the two main spectrums. So most often, the proximal deep vein thrombosis is what's likely to embolize. But given the right characteristics, a distal deep vein thrombosis can also embolize. So the second picture you're right is just showing what happens when the clot moves out from the deep vein, gets into the pulmonary artery, where it can cause different presentations. So it can cause a catastrophic reduction in cardiac output, causing an obstructive shock, or it can localize in different parts of the pulmonary artery, cause different variations of symptoms, hypoxia, shock, and death in hospitals or. So how common is it after cardiovascular, after heart attack and stroke? VTE is the next most common diagnosis, and it has high mortality. It's difficult to diagnose because it can mimic several conditions. And I saw this in one of the emergency books, emergency medicine books, that patients who had died unexpectedly from a PE had nagging symptoms several weeks before, had contact with their physician. And actually 4% of them had been seen weeks or years. So how does it occur? So we have our individual risk factors. We have appropriate setting, like the inappropriate setting, and then we have a DTE formula. So what are the individual risk factors? We can do it as a specific pregnancy and racial factors and acute illness from So I will go in with this, but if you look in our Ghana cardiovascular guidelines, you see risk factors which are stratified into weak risk factors, strong risk factors, and great risk factors. So how do we evaluate? So we'll take a history, we'll examine, and then we'll classify whether it's high risk or not. And then using our test evaluation, we can go through. So guide us as to how to investigate. So I'll keep run through, and this is a patient of mine in 2020, and he graciously allowed me to use life. And if you look at the right lane, the matter is it looks red and it's presented with pain. And it said that edema, we can measure the count of about 2 centimeters more than the other, the likelihood of the baby had. But there's no clinical way. So what pre-test probability most often is well scored. Sometimes we modify those. So I have a long way to go. I'll just show this and I'll move on. So these are the characteristics that we determine, and then at the end of the day, whether it is likely or. So to diagnose, as I said, just in summary, you suspect ability to do a modified bone swing. If it's less than 2, then it is not likely. So you do your diagnosis according to our guidelines. If it's negative, you have a negative, but you don't. If it's positive, go ahead, but not. And then if it's confirmed, if your score is high, but the feature for the high, then you don't do the diagnosis, go straight to compression also not be do. So what's a gold standard for diagnosing anybody? Practice. Anybody? Okay, so it's a contrast measurement. It's hardly done because it's invasive and a Doppler ultrasound can give you information. So how about the P? We also know the components of the modified load for, and we tell us that P is like or it's not. And just a caution that these pre-tests programs work better for young people. So when you grow older, the sensitivity of these tests reduce. Those without comorbidity, because the older you are, the more comorbidity you have, and those who are not hospitalized, and then those who don't have a heart issue. The ones who are in this category, the pre-test programs will go away, as well as if the younger and didn't have comorbidity. All right, so we'll come back to this slide, but then let's remember that when you suspect pulmonary embolism, you have to determine whether the person is stable or unstable. Now determine your next steps. So when the person is unstable, we're going to immediately start with the steps. If the person is stable, then we want to now diagnose and antibody. So we'll go through. I just put this in because depending on your design, you can actually decide not to. The well score, you can decide if you want to go further with testing using your design. So you do your well score and it's no probability. Then you want to rule out pulmonary embolism. So you go through all, then you have to tick every one of the 8. And if you can rule them all out, then there's no need to test. But let's remember the initial thing I said. So this is an ECG of the patient. So, can anyone see anything that is quite telling? Anybody?
Yeah.
Yes.
There is a deep S wave in the 1 and deep Q wave in the 3 and T wave inversion, as well as right ventricular screen, which is V1, V2, V3, sometimes V4 of the T wave inversion.
Great. Thank you very much. And the rate is irregular. So you don't often see this. But if you do, if you are fortunate to you look for a B or some many balls in the right hand. Okay. So this was my next slide, but we can do it. How do you compare the diagnosis of PV or fertility? Do you use the CGPA, ECG echo, or excess rate? All right, so we go to anticoagulation. And maybe I can ask how many have access? Computerized tomography, pulmonary and CTP. Okay. So I see about 3 people presenting to me actually 3 or 4 people. So how do the rest of them? All right, so we'll do a full history of failure and then we'll go into. So from what I read, in 400 BC, Hippocrates, father of medicine, had noticed that blood was being to congeal when outside the body. Then later on in the 1500s, an Italian doctor also noticed blood clotting within the skin. Not too long after that, a gentleman called Paul Marowitz, he was not photogenic, so I think anything. He did a few sort of stratified basic and the coagulation is very basic. We had 4 points. Right, so the first DBT that was documentation. So if you don't document it, you can't attribute. So this is what we have. A 20-year-old male, I think he was like most Ghanaian. He developed a natural swelling and he said that waiting the leg swelling was developed an isolation. And then he went to a shrine. Nothing happened. So he was advised to go to the tomb of a saint. Someone who was later canonized and he prayed. And after several days, he applied some dust under the tomb. He was instantly healed and lived 11 years. Subsequent to that, subsequent to the report of the committee in that gentleman, it was now frequently seen in pregnant women and breastfeeding women. And they thought it was due to evil influence. So milk that was retained cow. Well, it was not long before they abandoned that. And the history of BT management has come a long way. With the initial management, strict bed rest because it was thought that once you use, you could emphasize. And then blood bedding. And then cancer, the surgeon decided that they would ligate the femoral vein or the iliac veins just to prevent propagation of the clot or embolization. Which is that's quite simple. And then everything was discovered and more. So this gentleman, the young man, J. Patrick was a medical student in his second year when he discovered a substance which made blood antibody. And eventually his mentor worked on it and he was working now doing an operation. So later on, the 1960s, heparin is now commercially. So I think we go a lot in this year. So anticoagulation, why when to anticoagulate, what to use, which one, when, how long should we anticoagulate? So it depends on, so I'm focusing more on pulmonary embolism because they are the ones that will cause significant mortality. So, classified pulmonary embolism as either massive, submassive, or non-massive, according to our cardiovascular guide. Ghana. So the massive ones are the ones that come with contracting shock and hemodynamic instability. And you need to initially stabilize the patient until when you remember you need oxygen, you need intravenous fluid, sometimes you need some inotropic support. And then if the resuscitation is not adequate or is not able to stabilize, then probably we need to support like either chemical or material. All right, so to initiate anticoagulation, the video is so I mentioned and the European Society of Cardiology classifies it comparative high risk. That's a feature of the anticoagulation. So the pulmonary embolism severity score, this put it there, and I'm sorry, I'm sure you can't see, but it's one that helps us to determine how severe the mortality within 13 days, risk of mortality from pulmonary embolism, and whether you are able to manage the pulmonary embolism outpatient or whether you need to act. Why do we anticoagulate? Want to prevent recurrence of pulmonary embolism? Validation ended. This is my last slide. What medications do you use for the treatment of? So we did a develop oral anticoagulants or old still useful heparin and warfarin. So what do we use? And it depends on the number of factors. The patient characteristics, the person doesn't have renal disease, does he or she have liver disease, whether the patient prefers, I know most people will prefer oral, may want to use both, and patient characteristics, person pregnant, and then our experience. So how much do you know about the newer oral anticoagulants and how comfortable are we using them? And then how available are they? And if they are available, how pricey or not are they? And then what is the side effect? So which one to use? So there are several types. We have the parenterals, we have the orals, we have the combination. Examples of the parenterals, we all know the heparins, unfractionated, movement-related, and injectable captain inhibitor, parenteral fluid, and then the oral ones, stabilize warfarin, and the captain inhibitor as then direct. So let's look at the targets for anticoagulation. So the heparin, what do they do? Inhibit 11, 9, 7, and 10. And at low doses, they inactivate only 5%. So in effect, what they do is prevent progression of heparin. What are the good things about heparin? Onset of action is almost immediate. When you use it tremendously, you can expect that your anticoagulation effect starts at that moment. It's flexible to use and titrate. You can discontinue when you want, and you can monitor the action. You can use unfractionated always without it's active. But then it has a short half-life to use those treatments. And we don't have any oral formulation. It doesn't affect the already formed blood. So the chlorus and so explain body. Similar to low molecular weight heparin, which has a less effect on the inhibition of therapy. So it potentiates the effect of anticoagulation, and we have enoxaparin and dalteparin, I think, which we are more used to. Right. So what are the things? The video is predictable, you can continue when you need to, and you can monitor the activity. But then in radar dependent, you can't use it. You should use it with caution, depending on the PGFR. It's also indicated in every division both and you don't have oral formulations. All right. So oral anticoagulants. I mentioned that the patient is unstable. You need to research and manage. So you wouldn't want to do an oral. You can be very educational or something like that. You want to do oral. Pregnancy and breastfeeding can't use either unless the person is not breastfeeding. And then severe renal impairment. So warfarin was initially used as a pesticide in rats oil, but then in the US approved it for that was a lot of things. So what does it do? It inhibits vitamin K dependent on the and warfarin is good. No problem. Daily dose and you can measure the activity and reverse it. But you would need to have an initial parenteral dose, which fortunately may not. And you need to frequently monitor. And it appears with lots of clinical investigation. There's also quite high risk. So when I said it's low cost, and I think we'll put that in perspective, because then you need to have someone coming in out there with iron are monitored on a frequent basis. So the newer or new oral anticoagulant is direct oral anticoagulant. Have oral and subcutaneous. So the bacteria is test. You have Europropan, then the direct only because you have that and you can see, I think I mentioned the vitamin K and vitamins and things. The direct only inhibitors, they reversibly and competitively inhibit the thrombin, so preventing cardiology from converting. Reduced risk of ED, and several studies have been done. Einstein, lots of studies have been done on fecal population, comparing the Rogaban or comparing the offering, and the reduced median risk. The positive oral formulation, and you only need to give parenteral medication before you transition. However, you know that if the person has started cost is one of the negatives, and the fact that it goes twice daily. And well, there are reversal agents, but there are no true reversal agents. I know that there are some that are developed. I'm sure I think brother will be able to tell us. And then we have a parenteral hypertension. That's useful when you have a look at it. You don't have it. All right, so that is also one of the direct tests. And I mentioned it's not available, but hopefully you'll be able to get that. So as I mentioned, the number of people that have compared direct oral anticoagulation, vitamin K, and head on head, direct oral anticoagulants have not been said much comparing each against the other, one against the other. But then this study was performed in 2012 and was to determine the efficacy and safety of novel oral anticoagulants for acute venous thrombosis, thromboembolism. And this was a meta-analysis of 30 randomized clinical trials. The population was patients had acute venous thrombosis events which had been objectively diagnosed. The intervention was either treated with a new or novel oral and warfarin and the outcome measure was that there was no change. The outcome measure that was recurrent because of bleeding and all of that. And there was no difference between the drugs and vitamin K, and except that the glaucoma was found to reduce the risk of major bleeding. Right. So we're comparing direct oral anticoagulants and warfarin. And I remember we mentioned most of these today. Direct oral anticoagulants. Lower risk of bleeding. You don't need the parenteral formulation. And you don't need to give a therapeutic window, which is sometimes very difficult to achieve when you're using warfarin. So that's where drugs will have an advantage. You also don't need to monitor them frequently, but the effect is quite, I see, standard. Not like walking that you can get in and out of the have a risk of okay, so what are the bad sides of warfarin? So the fact that median risk is higher, you need to constantly monitor. You can have peers with a lot of medications and all right. So when would warfarin be useful? So warfarin would be useful when what's possible from the concentration. When you need to do multiple interventions, multiple procedures, you need to monitor how effectively either anticoagulated or not. Warfarin will be a good one. You can always monitor. So that's good. It's a once daily dosing. So for people who may not want to take medication twice a day. How long to use depends on what causes the patient to affect. So it's either provoked, so there's definite cause, so it's either trauma or surgery or malignancy, etc. Or it's unprovoked, so there's nothing that is definitely causing the patient. And you can either use long-term therapy, which is moved from happens here. Anticoagulation for 3 months, extended anticoagulation and then, depending on the risk of the patient profile, indefinite anticoagulation is needed. So I think I'll just summarize this slide that I picked up from activate. Just to guide our selection of anticoagulants. So someone who has malignancy, which is active or metastatic, would be better off using low molecular weight or pertaining to if you don't want to initiate parenteral therapy, rather is that some medications definitely require some parenteral therapy. Later in this anticoagulation, we want to do something that is easily reversed. And so we want renal disease, we want to do either unfractionated membrane or that's the thing. And if dyspepsia or bleeding and the gastrointestinal tract is a concern, then it means that I can see a balance. Then with patients with poor compliance, you may need to see them more frequently. So you want them to visit you. So as a punishment, you'll come and do their clothing with every now and then. That's it. So if you are an eye now, you can check that they are within your range for it. And with the direct oral anticoagulants, realize that the half-life is also quite short. So if you stop it, you are at a high risk of getting a thromboembolic event as compared to walking, which has a long half-life of 40 years. I would recommend you. Right, so thrombolytic therapy use we want to do unfractionated inflammation. And if you do need a reversal agent when the person is high risk of injury, then better off using the more fractionated enter direct oral antibiotic. In pregnancy, you either use a low molecular heparin or fractionated heparin. So there's a potential for the medication to be for. And then when cost coverage and licensing is a problem, and you need to look at where you are from. If you're in Accra, maybe you have more access, more people will be able to afford certain medications compared with people in other parts. When you need more anticoagulation, so I mentioned that which needs to determine whether people are either stable or unstable physically, and then you need more than anticoagulation. You either want to mobilize, get the blood pressure down, you can shock, or or antibiotic. So putting it all together, I want us to reflect on the kind of patients we have as family physicians. What are the patient characteristics? Most of the people with multiple people on a myriad of medications, sometimes 7, 8. People you told to talk to icon signs and it's exciting. And rather such vegetable. So really vegetables you are recommended and they're going to interact with some of it. How about these conditions? So tuberculosis and then medication that I use pharmacy. Active antiviral therapy. These medications have been shown to interfere with certain medications. So look at the patient active. Provide patients and them. So that's our reflection. So what should the family physician do? I'll leave that to us. And we are care providers. We are researchers, and I'm very happy ever with this. We have the opportunity to advocate, to be advocating for certain education on national health insurance or to be available to certain populations. That's absolutely nice. I think lastly, I would say that we need to communicate. The number of people who we put on anticoagulation after a month, they forget the number of them come back and we have another event. So communicating to your patients, probably even asking for someone who is trained in clinical psychology, reinforce the fact that they need to be on the So I'll leave you with this final. Let's remember, we also are in a terrain where we can prevent chronic events. So let's look at the patient characteristics. We need to admit them. When they are admitted, what do we need to do? We need to destratify them, give them remote prophylaxis, early mobilization after surgery. That is an average. So I think I'll end there and say a very good yeah.
Thank you very much. Lua. Thank you very much, Lua. That the child that effect of last year when people tried to go on the talk about some people were holding people in the spirit. Thank God we were able to go through it. Thank you very much. I must say that we are privileged to have a lot of sponsors who have got that through this program. I appreciate AstraZeneca, the club, Novo Nordisk, Novartis, Johnson and Johnson, Symbiotica, Sanofi, Salina, Megalite, then and the others. We really appreciate you. One of our sponsors is given a special presentation. Just a 5-minute presentation and over the group. Everyone was trying to say a lot of things and having a lot of education. Telling that some of the new trends, some of the new education that are now. Only right here, the one of this as the giver, very short, 5 minutes.
Thank you very much. So, thank you. Is it, am I on? So thank you very much for as a human, I work with all of this is just even more this in endurance. Please permit me to speak faster than I usually because I have this fight. I have 7 minutes. So there are no heavily promoting antidiabetic agents, specifically insulin and not including that injectables. We've been doing that for the past 100 years, between 1953 to 2023. Also focus on other conditions such as PDA and that's just even one in advance. So today I'll be speaking specifically on basal chromosomes, one of our modern basal chromosomes, and that is specifically correct. That is specifically transceiver. So what is transceiver? Transceiver is ultra modern, long-acting data. Why do we say long-acting ultra modern? It's that because of the pharmacokinetic property. So it has a half-life of 25.4 hours. Duration of action of more than 52 hours is approximately 48. That is why it's ultra long-acting data because it's prevented from CA. So when we look at transceiver, this is the structure of the receiver. So some amino acids have been substituted in the structure. This is very basically how it looks. Now, how does it work when it's injected? Whenever it's injected, what happens with that payload is when it dissolves, it forms chains of multi-headlines. And when it forms chains of multi-headlines, then finally it's going to go with the and then it forms breakdown of hexamers and finally movies. And when the movements are gone, this can then be absorbed into circulation. So the transceiver basically forms a depot in the subcutaneous tissue. That is how it works. So because of this property, it confers on it a predictable mode of traction. We will focus basically on three major benefits of transceiver today. First of all, looking at the flexibility in the movement. When it comes to flexibility in movement, the drug has been modified in such a way that the patient can actually come to you and family physician and say that looking at my schedule, I can decide to inject either more or inject every day. Okay? I can decide to inject every day now or every day. It's not always multi, but you see that there's that flexibility. And another better flexibility when it comes to flexibility is that when you miss a dose, you are to AMA country or something, you put AMA on this. What happens is maybe AMA starts injecting every day, 10 minutes a week. So she starts to get more. If she remembers Sunday that she didn't inject Saturday and what does she do? Does she wait and inject Sunday night? Or does she just continue? Now, if she's supposed to get today, and then she forgot to get tomorrow, then she remembers Sunday in the morning. She can still inject Sunday in the morning and then continue with her regimen. But she goes within the 8-hour window period and then the 40-hour window period. Remember that the receiver has a duration of action of between 42 to 8 hours. That is why it gives patient that even when they did. So the second benefit is the day-to-day variability. Now this head-to-head study is actually conducted comparing it to the comparator that has been in the market for a while. Now it was to see how flexible the readings would be throughout the whole week. So between 0 to 24 hours, how the receiver acts. So if you take the patient into treatment, within 24 hours at every interval, when you read the reading, would you get similar readings or would you get fixed from the receiver or either me and then larger in the blue bar? Now when you look at it, you realize that that's similar movements between 0 hours to 24 hours. So this bar chart just tells us that if a patient gets receiver on a daily basis, there's that predictable mode of traction. The likelihood of him or them having peaks and troughs will be highly basic. Now, when we come to the third benefit, which is hypoglycemia. So hypoglycemia, this was actually several studies that were conducted, and meta-analysis that was conducted. There was picked from the gain switch reports from new sheets from them reflex studies. Now, basically, this study is telling us that they are focusing on three major hypoglycemia. They are looking at overall compared hypoglycemia, natural, and severe hypoglycemia. For these three major hypoglycemia, they are looking for, they are comparing to to the comparator other than being on the. Now, we are looking at how these two react, or at the end of the day, how would the results turn out. Now, when you look at the meta-analysis, realize that for the forest results, its eye graduate is on the right and the transceiver is on the left. Realize that the forest results favors more of the one on the product on the left, which is transceiver. So basically, this forest results of this meta-analysis basically tells us that if the patients are displayed on transceiver, the likelihood of him or them having hypoglycemia, whether overall, external or severe hypoglycemic highly. Now, which patients benefit from transceiver? Patients who are 1 year and above type 1 and type 2 diabetic patients, patients who are various stages of cell dysfunction, patients who need to start improving operation with another big cell component. Those that have experienced hypoglycemia have been injected separately and are still not getting the transfusion. Patients with irregular lifestyle, so those are very busy and they cannot stick to a specific time when it comes to injection. The fever for such a patient, the lab are not busy. Those that have public pathogen and postprandial diseases are still not having these patients will face treatment. Now, if we look at how to initiate and maintain a patient for insulin naive patients, the company suggests taking, however, for a healthcare practitioner using discretion can mostly use between 0.2 to 0.3 millimeters because definitely everyone points the and start the patient from that. Now, if you are switching the patient from one basal which relates to transceiver, because we are both in the same class, you can maintain the patient in that same. If you are venture the patient was injecting 12 units on another basal unit, you just switch the patient on to transceiver 12 units, won't change. Then finally, the patient is the slightly different class. If you are venture the patient is on pre-mixed insulin, the patient will be texting. If you want to switch that patient on to transceiver, what you do is you do a 20% reduction. So basically, if AMA is taking 30 units of the pre-mixed, basically you 20%, which is 6 minus 6 units. You start the patient with 54 units. And this is how transceiver is. The transceiver comes as one in the pattern. So the color is neon greenish yellow. Not all this specific color, this is how it looks. One in the pattern. And this is how it looks like. The neon greenish yellow. So it looks this way. This is how the pen looks. And it is available in all the facilities that all of us will get. It is. Now, is it available in the pharmacies? Yes, it is. Is it available in the community pharmacy? Yes, it's available. How much is being retailed at 288 per penny? Yes, I know some of you scream, but the good thing is because it's a big sample, so the patient can even use as low as 10 units. He or she will just be using this thing once. So thank you very much for all.
Thank you very much, Madam, for your presentation. The question will be coming on the board. Anytime that there's presentations, the question comes on the board. Please, therefore. Next to do the presentation was a very good friend. He's the only cardiologist among us at the moment. He is with the Bank Hospital. Special interest is actually in the device therapy and non-invasive cardiology. He's a fellow of the Ghana College of Physicians and Surgeons. Ladies and gentlemen, help me welcome Dr. Foster Fufuo. In fact, Dr. Fufuo is being from the Eastern region. I think he started his practice and most of his practice here before at the Bank Hospital. Later today. Thank you very much.
Good evening, everyone. My name is psychologist from France. I'd like to thank the organizers this PDS for inviting me to come and talk for good representation of anticoagulation from the university. As you are all aware, if you put here any of the emergency fields, the plan one was patient. I look these are the that was so that's the other and also talk about anticoagulation and their mechanism. And we also talk about indications of anticoagulants, the conditions that what time specific. Definition of thrombosis. Thrombosis is the formation of blood clots in the blood vessel that as a result of abrupt stoppage regards organs to life. Once thrombosis forms, affects organs and organs and function because of the thrombosis this actually leads to serious complications. So it's increased motivation. Commonest form of thrombosis that we know is arterial thrombosis, then venous thrombosis. When we talk about arterial thrombosis, stroke, ischemic stroke is a form of arterial thrombosis. And acute coronary syndrome, either STEMI, non-STEMI, or constipated angina, they are all forms of arterial thrombosis. And when it comes to the venous aspect, these are all serious complications or diseases that we have to address ourselves, parents, and management, so that we improve outcomes for our patients. To understand thrombosis, we have to understand that there are certain factors that come to play to enhance blood formation. Those factors that come to play is referred to as the Beckhouse trial. Medical school, we talk about Beckhouse trial. It comprises of TDI phases and hypercoagulability. And the TDI, as you can see, with atherosclerosis, chronic inflammation, or which is mostly what happens throughout the coronaries. And stasis as occurs because there is abnormal blood flow as occurs in people with atrial fibrillation. People with atrial fibrillation, they tend not to have good atrial contraction, and therefore blood flow is not as efficient as expected. So you have blood flow staying in the left atrial appendage because there is space there. And when the clot is formed, eventually this clot may move to either the brain or any other parts of the body to cause a thrombosis. Then hypercoagulable states that increase the risk of getting thrombosis. Pregnancy, malignancy, yeah, high form. So these three things can all activate platelets and also activate the coagulation cascade. When it's activated, eventually it will. So for clot formation to be formed, these things have dead. Now let's look at the coagulation cascade. It's important that we look at the coagulation. When we're med school, we all had issues with this particular, and we are asked to read about it and all. So I don't have the pointer here, but maybe I'll use the arrow. The coagulation system actually is we have the extrinsic pathway, and then the intrinsic pathway, and then the common pathway. It is important that we understand if we are going to talk about anticoagulation, we have to know where these anticoagulants are at and prevent your patient from getting clot. The extrinsic pathway, as you can all see, usually starts from or if that results in a substance or a protein being released called tissue factor. And when tissue factor is released, tissue factor combines with another protein called factor 7A. And when factor 7A and tissue factor combines, then they move on to go and activate factor 10, factor 10A. Once factor 10A once factor 10 is activated, factor 10A, factor 10A will then combine with factor 5A and then cause the conversion of prothrombin to thrombin. And then thrombin will finally convert fibrinogen into fibrin, leading to the formation of. So that is the extrinsic pathway. And then the intrinsic pathway actually results from if you have a contact activation of a damaged platelet, actually results in factor 12 being converted to factor 12A. And then this factor 12A will move ahead and then activate factor 11, factor 11A. Then factor 11A will also move on to activate factor 9, 9A. Then factor 9A in combination with factor 8A will then activate factor 10, factor 10A, and then the clotting cascade continues. So this is what is called the coagulation cascade. You have to understand. So if you look at the coagulation cascade, you can see various points that we can use medications to block it. Other than that, the clotting system or the clots keep on forming and your patient will not get it. So we want to use vitamin A. Vitamin A is going to inhibit what we call the vitamin A dependent protein 2, 7, 9, and 10. So if you look at the slide, prothrombin can be inhibited by vitamin A, factor 7 can be inhibited by vitamin A, factor 10 can be inhibited by the vitamin A, then 9. Then if you look at conversion of prothrombin to thrombin, that is where factor 10A acts. So if you look at the direct oral anticoagulant or the deep oral anticoagulant that my sister did mention, like rivaroxaban, apixaban, and all that, they prevent the conversion of prothrombin by blocking factor 10A. And then if you look at the thrombin inhibitors, dabigatran, what it does is that it also blocks the conversion of fibrinogen to fibrin by blocking thrombin. And then our heparins also act by blocking thrombin and then factor 10A. So understanding this particular slide will help you understand how the anticoagulants work, how we use them. Warfarin, vitamin A antagonists, the fractionated heparin, non-fractionated heparin, thrombin inhibitors, and important that we prepare thrombotic events in that we reduce cardiovascular mortality. If somebody has a risk of coming from this, and you know that this patient has a very high risk of coming from this, and you put in measures that will prevent him from coming from this. Eventually, you reduce the patient's ability or chance of getting cardiovascular event, being either stroke or myocardial. It also prevents disabilities. I mean, people with stroke may be breadwinners of their family, and suddenly he gets stroke. He gets a disability. All his dependents will suffer because this time the breadwinner no longer bringing in the house because he's fed family. It also avoids recurrent events. Sometimes people will get events and they will survive, and then you realize that oh, this particular person, if measures are not put in place, he may get the event again. So once you put in your measures, it will prevent the person from having recurrent events, like people with ischemic stroke. Once you get a person and you put in the measures, secondary stroke prevention and all that, the patient is not likely or is less likely to get recurrent. And then it's good overall health outcomes. And it also reduces healthcare costs and public health, enhances treatment in public. So these are the advantages that we get if we are able to prevent our patients from getting IV myocardial infarction. What's anticoagulation? It's a process of inhibiting blood from forming or preventing existing blood from getting. That is the definition of anticoagulation. We want to prevent the blood from forming. Sometimes if you are not putting in the blood has already formed, we want to prevent that from forming. That's the definition of anticoagulation. And it involves targeting the various components of the coagulation cascade that I showed. We use medication, target the various components, prevent the propagation of the clot, or prevent the clot from becoming big. That is the definition of anticoagulation. And there are several anticoagulants. The components that we use, warfarin has been in the system for a very long time. In fact, it has really helped medical practice. It was just in the 2012, 2013 thereabouts that warfarin started having challenges. And some of the challenges that come on board direct oral anticoagulant. In spite of those challenges, still warfarin has a role to play when it comes to anticoagulation management in preventing cardiovascular events. It acts by inhibiting the vitamin A dependent protein by 2, 7, 9, 10. And then the only thing is that it has a narrow therapeutic window. You increase the dose more, the patient goes beyond more than 3. You reduce the dose, increasing the patient risk of death if it goes beyond 3. You reduce the dose of warfarin, then you come 1.1, 1. And then increase the patient chance of getting a stroke by thrombotic. Then it tends to be affected by food and some medications. Warfarin requires diet monitoring with iron. So sometimes it becomes very cumbersome. You realize the patient will be coming to the hospital in and out because you, the doctor, want to know that he's gotten to the right target. And it has a lot of cost the patient's care. And heparin, we have unfractionated heparin and then low molecular weight heparin. It works by enhancing the activity of anticoagulation, and then anticoagulation will then inhibit thrombin. So that's the mechanism of action of heparin. They enhance the activity of anticoagulation, and anticoagulation will be able to bind thrombin and also factor 10A and then prevent the coagulation cascade. The difference is that the unfractionated heparin tends to affect both factor 10A and then anticoagulation, whereas the low molecular weight heparin leading the person getting what's called pulmonary hypertension. That is thromboembolic pulmonary hypertension. You also require therapy. Then for therapeutic purposes, when somebody has thrombus in the heart, you have when somebody has coronary arteries, acute coronary syndrome, either STEMI, NSTEMI, or stable angina patient comes to you, definitely they need some form of anticoagulation. Now let's talk about atrial fibrillation. Atrial fibrillation is the commonest breathing abnormality that we get to see in cardiovascular crisis. Tends to be very common in elderly people. Most people with atrial fibrillation are old. And what atrial fibrillation does that if care is not taken, can let your patient get through. It can be picked up easily just by examination. You put your hand on the patient pulse, and then you realize that the patient has an irregular both in volume and in rate. Then you suspect that. Well, your lack of leeway or lack of distinct leeway. So as you see on the slide there, you don't see clear leeways. And then you also realize that there are QRS complex intervals. Then you can say your patient has. As I said, it's an independent risk factor for stroke. It is present in about 20% of patients with first-time stroke, and it contributes to increased morbidity and mortality. Atrial fibrillation accounts for about 15% of strokes in persons of all age, and 30% of strokes in persons more than 80 years. So atrial fibrillation is one of the debilitating complications of stroke, especially in the head. It's always important that you assess the risk of stroke in your atrial fibrillation patient, whether it's paroxysmal atrial fibrillation, whether it's permanent, persistent, you have to assess the risk. Apart from stroke, there are other things, complications that you can also see in atrial cardiovascular mortality. How do you manage AD? There are certain pillars that you look at. You want to control symptoms. You control symptoms by either controlling the rate or rate control and stroke prevention. Then you manage the activities. I will focus on stroke prevention. That's why we're here. The stroke prevention is where we use anticoagulant. The various forms of stroke prevention for atrial fibrillation have been pharmacologic or non-pharmacologic. Pharmacologic is where we use our warfarin, our Xarelto, our low molecular weight heparins and all that. But non-pharmacologic is where we have something called left atrial appendage occlusion. Atrial fibrillation, the atrium is like an output. What is called the atrial appendage, and most of the time, because the atrium is not kicking as we want, it fibrillates. As it fibrillates, there is one of the mechanisms for blood formation called stasis there. That stays there, and then the blood is formed. But eventually, because atrial fibrillation, they move from sinus to they move in and out of atrial fibrillation. Once the clot is formed, then the atrium gets its contractility back. The clot that has been formed will squeeze out of the appendage, goes into the left ventricle, and can go anywhere in the body, the brain, the legs, causing peripheral. So these are the management for stroke prevention in atrial fibrillation. And you cannot put somebody on anticoagulant, somebody who has atrial fibrillation, you can't put an anticoagulant without having a risk for what's called the CHAPTER score, or risk of forming stroke, or risk of getting stroke. The CHAPTER score is actually used to assess the patient risk of getting stroke. Atrial fibrillation alone doesn't lead to stroke. If the person has atrial fibrillation, and then it has a lot of the risks that you see on the slide, either being congestive cardiac failure, either being diabetes, or you add all the risks. And then if you get the risk scores that is high, or 2 or more, your patient will require something. You realize that the annual risk of stroke actually increases as the CHAPTER score increases. So if somebody's CHAPTER score is 1, its annual risk of 1.3%. If somebody's CHAPTER score is 8, annual risk of is about 4. So once you get atrial fibrillation, try and use this particular risk to help you whether your patient is high risk of getting stroke within the year or not. And then when you calculate the risk score, if you get a man whose score is greater than 2, it's 2 and above, that person is anticoagulation. If you get a woman whose score is greater than 3 and above, it's anticoagulation. If you get a man whose score is 1 and a woman whose score is 2, oral anticoagulation may be considered. If you get a man whose score is 0 and a woman whose score is 1, it's reasonable to be. So this is the criteria that you use to know whether your patient will be calculating the score. Then you decide as a score to give. You cannot put somebody on anticoagulation without estimating the patient's risk of bleeding. So in AV individuals, we tend to use scores for the Haslet score. We want to find out the risk of bleeding. So sometimes it's good to do this because when you calculate it and you realize that your patient has a risk of bleeding, you ask how do you mitigate this patient's risk of bleeding so that the risk will come. For example, a patient's risk of bleeding is because he takes alcohol. A patient risk of bleeding is because he's on some form of antiplatelet. We have to let the patient do away with those things, and then it reduces the patient's risk of bleeding. The fact that somebody's bleeding rate is very high does not mean that you can't put him on anticoagulant, especially when he qualifies for anticoagulant. So you do the CHAPA score, 3, the patient qualifies for anticoagulation. You do the HAS score, you get 4. The patient has a very high risk. It doesn't mean that you shouldn't put the patient on anticoagulant. Rather, you have to look at what you are seeing and decide as how to prevent the patient from getting bleeding. So you put the patient on anticoagulant, but you have to come frequent monitoring in order for you to be sure that it's not getting the complications for the anticoagulation. And at the same time, it's also benefiting from the anticoagulation so that you will not get a stroke or a heart attack. That's the aspect. Now the choice of anticoagulation. When we talk about atrial fibrillation, we have what's called non-valvular atrial fibrillation and valvular atrial fibrillation. For non-valvular atrial fibrillation, that means that it's not a valve that's causing the atrial fibrillation. All guidelines, the ESC, AHA, the European and the American, I will all recommend that you use direct oral anticoagulant for anticoagulation or for stroke prevention. And all these guidelines have come about with this particular statement because a lot of randomized control trials have been done comparing the direct oral anticoagulant work as to who at the same time will reduce the risk of complication from the anticoagulant being used. And most of the studies that have been done have shown non-inferiority to warfarin or superiority to warfarin. Apart from non-inferiority or superiority to warfarin, direct oral anticoagulants are easy to use. We don't need to do any monitoring. We don't have a lot of sort of interaction with them all this. They have rapid onset of action. So now the drugs have been accepted as the number one choice when you are considering giving somebody anticoagulant because of non-valvular atrial fibrillation. And the trials that have supported this particular statement, there are several of them, but the READY trial compared the information that are the Rocket 8 trial, and the Aristotle trial. Aristotle trial compared apixaban and warfarin, and realized that apixaban was superior to warfarin in stroke prevention. A lot more people who were on apixaban had less stroke compared to the people who were on warfarin. And a lot more people who were on apixaban had less complications from the anticoagulation that the apixaban is compared to warfarin. So now these drugs have come to stay as the drug of choice in managing people with non-valvular atrial fibrillation. So if you look at this is the Kaplan-Meier curve. If you look at primary efficacy outcomes and then safety outcomes, you realize that the primary outcome was stroke prevention or systemic embolization prevention. And if you look at apixaban and warfarin, apixaban actually reduced the number of people who were having events compared to warfarin. And then if you look at the primary safety outcome, those who were having bleeding, the bleeding occurred more in the people who were using warfarin compared to apixaban. So it translated to people living longer. They were not dying and all that. So now it has been established that when you have somebody who has non-valvular atrial fibrillation, your direct choice to do your direct oral anticoagulant. But that is not to say that if the patient cannot afford intentional, the patient should be on the direct oral. Warfarin is there. Warfarin can also be used, except that you need frequent monitoring back and forth and all that. If your patient cannot afford the direct oral, go back to your warfarin. Now let's look at anticoagulation valve. The first one was non-valve. This one valve. That means that the atrial fibrillation has a valve component. There is a valve problem that is causing atrial. For example, if you have severe mitral stenosis, the blood is not entering the left ventricle, so eventually it stays in the left atrium, and then the atrium becomes irritable, and then you can get atrial. Such instances, your choice is war. There's no argument. If you have atrial fibrillation with moderate to severe mitral stenosis, your choice is warfarin. If you have atrial fibrillation with mechanical valve, your choice is warfarin. Trials that have been used nowhere in this particular has not been very good. Warfarin is a recommended drug for valvular atrial. Then the dosing, remember that warfarin, you have to start with 10 milligrams for the first 2 days. Then you want 5 milligrams for 10 days. Check the iron. You have to check the iron first, as I said. And when you start the warfarin, you have to start some of the low molecular weight. Because when you start warfarin alone, warfarin is promotenic in the first day, but it causes potency and head. So to offset that particular risk of forming clot in the initial phase of warfarin, you put your patient on heparin or low molecular weight. And once the overlap is finished, and then you have achieved your target iron, you drop your iron, your low molecular weight, or heparin, and continue with your warfarin. And subsequently, your patient will come to you with your iron. So that's, and then when it comes to the direct oral anticoagulants, the dosage that is used if the renal function is fine, is 20 milligrams once daily. Apixaban, the dosage that is used is 5 milligrams once daily. The dosaban 60 and the dabigatran 1. As I said, we have rivaroxaban and apixaban. However, if you realize that the patient's renal function is falling, you have to look at the indications. If my patient's renal function is in this way, what dose of rivaroxaban can I use? What dose of apixaban can I use? Very important that, because people with renal impairment tend to have very high risk. If you are going to add another anticoagulant to it, patient chance of being very rare. Just by twisting the dose and reducing the dose, let the patient become sick. Now let's look at coronary artery. You all know that this one actually results from either blood pollution or backlash. Somebody who is taking complete occlusion of the coronary artery, either the right or the left. And it's all acute coronary syndrome. So acute coronary syndrome can come in the form of STEMI and STEMI. It's the life condition associated with increased mobility. So when you see your patient, your hospital, and the patient has either life that quickly, other than that, the patient will die in front of you. There are 3 modes of management and acute coronary syndrome. The commonest that we all know that have been found very, very efficacious is DCI. DCI is where we take the cath lab, where I live and everything, where the clot is, then we put our stent balloon in and we are done. Then the other one is fibrinolytic therapy, where if you don't have PCI service, or you think when you are sending the patient to a PCI center, it will be delayed, if fibrinolytic therapy, the next place or out place, where and break the clots. And then the final one that most people do in Ghana is the medical management without it, which is very most part of the country, they don't even have the time. So what they do is medical management. Yeah, fortunately, the patient will survive. It has been found out that anticoagulant has a crucial role to play in all this, irrespective of the mode of management, you still need anticoagulation. And you have to start early for your patient to get better. So if you are in the hospital, somebody comes acute coronary syndrome, every month or anticoagulant. The European Society of Cardiology guidelines recommend class 1A indication that parenteral anticoagulation is recommended for all patients with acute coronary syndrome at the time when you diagnose your patient as having acute coronary syndrome. and think your patient is going to PCI, unfractionated heparin. And the dose is what you get 70 to 100 international units given to the patient, taking to the and then sometimes when you do the extent, you may have to continue for like 2 days or 3 days before eventually you leave your patient with the double antiplatelets, statins, and other drugs that your patient needs. With a class 1A indication that PCI patients, they need anticoagulation. Then, if your patient is not fortunate and he goes for fibrinolytic therapy, you also need anticoagulation. If you give your blood plastic either kinetic or all after you have perfused it, you put your patient on either enoxaparin or unfractionated for about 3-4 days to make sure that the fibrinolytic success is maintained. Other than that, your patient can come to us again. It's very important. So this is just a confirmation of the fact that if somebody gets fibrinolytic therapy for acute coronary syndrome, the patient needs some anticoagulation. You can use either enoxaparin or unfractionated class 1A indication. That's the patient. For those who are not fortunate and then they are managed medically, maybe in some village or some district that doesn't have all the means, you still need heparin. You can use your low molecular weight heparin at a dose of 1 milligram per kilogram with BD. Then you add your double antiplatelet, aspirin, then you add your high dose intensity statin to your patient. And then you manage them for the course of stay in the hospital. And eventually you discharge them double antiplatelet. If you don't have enoxaparin, you can use heparin. It also works. This is the dosage. I think we lost 60 international units per kg. Then you can give 80 international units per kg. If you don't have perfusion, you can decide to maybe 10,000, 8,000, whilst giving for 10,000, depending on the patient's rates. End-stage people with end-stage require antibiotics. So you have to so that's the class 1B indication. You can use iron, you can use unfractionated. So you realize that people with acute coronary syndrome, irrespective of the type, they need antibiotics. Then people with left ventricular aneurysm, those with left ventricular aneurysm, they have a high risk of forming clots. Because if you look at the output share, blood flow here will be very static. Definitely can form clots here. But all the guidelines are not so robust in terms of putting everyone with aneurysm on antibiotics. If the patient has aneurysm and you find clot there, then definitely you need antibiotics. If the patient has aneurysm and then he has some form of enrichment, extra enrichment, definitely you have to the patient some of antibiotics. Then if you have a clot, as you can see on the slide, sitting in the left ventricle, this can result from either myocardial infarction, can result from either somebody with dilated cardiomyopathy, somebody with infected endocarditis. They can all form clots. Once you see the danger, that's in there can do anything. So quickly start anticoagulation. You can use your warfarin. But these days, people are using even though there are no studies to actually prefer their use. I think people use it because of the ease and all that. That's why they use the word left. Whilst the left ventricle was there and you are managing, monitoring your bleeding complications and all that is very important. The same with left ventricle was this, I'm sure some of you, I wanted to take this one out. It's prosthetic artificial heart. The moment somebody gets an artificial heart, it's a foreign into the body. Definitely to attract leaflets and contact. This care is not taken. Adding glasses and having done it was 9 was valves. So we have 5 and mechanical valves. Indefinite anticoagulation therapy with warfarin needed. Then drugs or direct anticoagulation don't go there at all. It's warfarin. So that place, warfarin is still there for the hands, including things. when the person has a mechanical valve. So somebody who has aortic valve replacement and is warfarin, they tend to say the target INR is 2 to 3. If he has aortic valve replacement with a mechanical valve and he has a very high risk of bleeding, then your target is 3. Mitral valve, metallic mitral valve, target. So whenever the patient comes, you know that this patient of mine has a metallic valve issue. My target is always reached with an INR. If you do antidosing and you don't get to the target high, the valve patient dies. There were studies that were done to look at the new oral anticoagulants or direct compared to warfarin in this prosthetic heart valve. Then the trial was stopped. It's called the realign study. Stopped after they had treated about 253 patients. They realized that those who had surgery and then were people from that they were having a lot of costs bleeding compared to those who are warfarin. So because of this, the direct anticoagulants are more recommended. For those who have prosthetic valve, they tend to require some form of anticoagulation in the initial steps. Subsequently, if they are risk of having thrombotic effect is not high, they tend to put them on their aspirin. If their risk of thrombotic effect is very high in the context of prosthetic, then definitely they will also require to work. Now let's talk about anticoagulation in heart failure. You know, heart failure with reduced ejection fraction. They have a very high risk of forming because the ejection fraction is low, there is reduced cardiac output and all that. And we tend to see a lot of heart failure in our practice. Up to date, anticoagulating heart failure patients is not universally agreed upon because patient characteristics are different. Somebody will have heart failure with their ejection fraction. Heart failure with the characteristics are different. So the consensus is not clear. But what people are saying that if the patient has an indication for it, maybe heart failure with reduced ejection fraction, patient has anticoagulation, this anticoagulation. If the patient has heart failure, reduced ejection fraction, 35 and low, he is at risk of forming fractions, always in sinus within. There is no benefit when you give them anticoagulation. No benefit. And the trial that looked at people with heart failure with reduced ejection fraction, but sinus within, ejection fraction less than 35, were two trials, called the watch trial and the watch trial. You were giving them warfarin compared to aspirin, and they realized that there was no benefit in giving somebody who has heart failure with reduced ejection fraction warfarin because we think they are at risk of forming because they are putting them. So that one is don't anticoagulate, provided they are in sinus. The only time you think people with heart failure reduce ejection fraction, some form of anticoagulation is when they come to the hospital. Maybe he has heart failure reduce ejection fraction. Has come with pneumonia, people will say, but admitting treated pneumonia. That's the period of stay that patient fast management. We give them prophylaxis. Can you like say just for the day? That's after the Tuesday when the patient goes home, don't add any anticoagulant to it. But leave that in the hospital, and then we go down, look cardiac output and all that. It's the same thing we do for people who are admitted and we think they have risk of getting put them in prophylaxis. After the prophylaxis, they go. The only time you put people with heart failure on anticoagulants when they have left ventricular thrombosis, when they have thromboembolic events, when they have paroxysmal or chronic AV, or when they have. So now, about management of anticoagulation therapy, it's very important that you know how to manage anticoagulation therapy very well, so that you prevent your patient from getting infected. At the same time, you prevent your patient from getting complications from anticoagulation. And it involves adjusting the dose order so that you get a fine balance for preventing clot and fine balance to avoid bleeding. That's management of anticoagulation. Very, very important. And these are the things that we may mention of individualization. You can't say that this patient is taking drug A for prevention of flu, so this patient will also take drug A. Different patient characteristics. Always make sure that you assess their risk of getting thrombotic event, their risk of bleeding, help you decide if you have to. And then selection of anticoagulants made mention. You have to know about the dose and then monitoring. Some of the drugs need INR, heparin, and then low molecular weight. Sometimes you can use kidney. But the drugs, there is no routine on it. You don't need to monitor to examine. And patient education is very, very important. The need for the patient to understand that he has to be on the medication for life. Sometimes you put the patient on medication for 1 month, 2 months, and you don't see him again. The next time you see him, start with a stroke. The patient will have to understand why he's on that medication, what that medication is doing. The side effects. The patient will have to understand the side effects of medication so that when he sees the side effect, he can quickly come to the hospital for you to address it. So tell the patient anytime that you see that you are bleeding or anywhere, your stools are down and all, you quickly stop the medication and come back. That is the essence of patient education. And then you have to know how to manage bleeding complications in your care. We all pray that if our patients are on anticoagulant, they don't bleed either from cerebral bleed or that's when they cannot bleed. Pray that it doesn't. But if your patient is on medication and those things happen, go the intervention that you have. That's my last. For example, a patient is on warfarin and he comes to that he's noticed that he has spots, red spots on there. Particular or some or the skin, but he's not bleeding. Please ask the patient to go and check the iron. If the iron is high, your patient is not actively bleeding from the GI. All that is put your leg on the drink pad, hold on with your anticoagulants, and the iron is 3.8 can be. Go home, come back, maybe 4 days, let me check where you are, or 5 days, then. But if the patient comes and is actively bleeding in front of you, management is different. You don't say pause. Quickly, for often you have to get your FFP by an A, then you have your fresh as you have to get you have the patient safely. If your patient comes with bleeding from the low molecular weight heparin, protein salts, the diet can be. And if your patient comes with bleeding as a result of direct oral antibiotic, there are new drugs that can be used to stop bleeding. Studies have shown that they are very, very effective. But I must say that I haven't seen some in Ghana. Yeah, the direct oral antibiotic, there is a drug, there is an antidote that we call anticipate alpha, used for Xarelto and Apizaban. Then the other drug for dabigatran, but that one is a dilution of those drugs are there that people use it in the weekend. For us, Africa, or Mexican, have this business happen. So, I'll see where the light was, right? What the light went on. So this is the individualization that I was at the management of bleeding complications, right? How to manage bleeding complications. Today, okay, your patient, you are anticoagulating. So warfarin, if the bleeding is excessive, having a high GI bleed and all that, need vitamin K, FFP, for good from response. Heparin, if the bleeding is very, very severe, need protein. And Then for dabigatran, you need either resistance antibody that you can use. Then for rivaroxaban and apixaban, we have antizanate out. There are studies that have been used, this drug has been used, and they found that they can cut the bleeding for about 85 to 90% of patients who were had a complication whilst on the direct oral antibiotic. The only thing is that we don't have some. So we have to be very careful, close monitoring, telling our patients that if they see any signs of bleeding, they should come up for it to be addressed. So in conclusion, anticoagulants are very important in preventing thrombosis. Have potential side effects of causing bleeding. Get the fine balance. Choose the right anticoagulation, the right medication. And you always have to do risk assessment for your patient to reduce the risk of bleeding, risk for septic clot, risk for bleeding, and then try and manage. And it's important that you individualize anticoagulation therapy and vascular disease management. Thank you very much.
Thank you very much for that. The one thing that can only be is that it's not only ABT, P that we anticoagulate. There are a lot of other things that we do. But know the indications, make sure that we have the right indications and know how to go about it. And it's not any patient with those complications that we need to individualize them. There were 7 points that were put up. The slide will be shared, make sure that we are conversant with it to can manage our patients better. I mean, one interesting question has come in when you say the PCI, the lives, but even in the cities, before they will get to Dr. Popo and hospital, there is already sometimes a number of better outcomes. The question has come in, will discuss. But one of our sponsors will be giving us a very short presentation as well. That's Biotica. Now, Sanofi and Pharmacy Biosys have come together. They are now called Biotica. So they are specialized in collecting and other things. So they are going to give us a presentation of that. Farm Jason Boys.
Good evening, ladies and gentlemen. It's good to see you all once again. My name is Henrietta Jessica. I'm a pharmacist with Sanofi. And just as we have been speaking of venous thromboembolism, we will also be talking about risk assessment, prophylaxis, and also treatment for venous thromboembolism with the use of a solution from Sanofi, which is not so new to all of us. We all have been using Plectin in our facility. This presentation is just a reminder of what we all know and also to reinforce the information that we have been sharing with us all. So when Tadora was speaking, she mentioned that just a few patients show symptoms of either a PBT or a PE. And she actually said that there are some patients who see their physicians some weeks prior to an event. And this goes on to show that just a few people will show symptoms, and that we should always look out for those that we can prophylax and those that we can give the right treatment as well. There's a burden of VT in our medically ill patients, and from research for the surgically ill patients or patients who are going through a surgery, the thromboprophylaxis is being done as a normal routine, mainly because of the risk involved. And I'm very excited that Dr. Popo also mentioned that in our patients who are on our ward too, if we check and they are at a risk of venous thromboembolism and other factors which will need or necessitate the use of anticoagulants, then we can also decide to thromboprophylax our patients as well. He also mentioned the virtuous triad, so I wouldn't go through that as well. And when we look at our patients with advancing age, those with some comorbidities, those who are immobile, they are at risk of venous thromboembolism and its complications, and these are the ones that can benefit from our flexing. So at Sanofi, we recommend a comprehensive approach, which is to increase awareness, just as we are doing today, and just as we do with our hospital meetings that we come to your hospitals to do, and also to ensure that risk assessment is being done for each of our patients. So for Sanofi, we have been engaging the nurses, and the reason why we do this is to ensure that they are taking note of every patient they have, ensuring that these patients are risk assessed, and they can also prompt their physicians and let them know that, oh, for this patient, I think we could add on anticoagulation to their treatment. And I think this is very important because our healthcare is something that we do together. It's a collaborative effort, and also to ensure that we give the appropriate prophylaxis and overall to improve our patient safety in our hospital. So this is a risk scoring system, which is called a Caprini risk scoring system. When Dr. Dora was speaking, she mentioned the Wells scoring system. So this is one of the risk scoring systems that can be used. And actually, we have adapted this as well, which we have as risk assessment forms in collaboration with some physicians. And what we do is that we share these with our nurses at the ward to pick up this information. So what they just need to do, or as a physician, if you have this type of risk assessment form with you, what you need to do is to take what applies to your patient who is in front of you. So let's say there is a patient who is 60 years of age, who is obese and has been on the ward for a stroke, or maybe has other comorbidities. Maybe the person is hypertensive, among others. We will take what applies to this patient. So let's say when we look at the first part, there's the age bit. So a 60-year-old will have the first risk, which is the age, which is 1. Then we look at the weight, which is BMI greater than 30. If that applies to your patient, you take that as well, which is also another score of 1. Then you look at the other risk that the patient might have. And if the patient has had a stroke, you take it as well. So this is how the risk scoring sheet is. And this is the adapted version that we have in collaboration with some physicians in Ghana. So for this one, we share it across at our various hospitals so that we can all take steps to ensure that every patient is risk assessed. And just as Dr. said, he said that we should ensure that we are individualizing their therapy. And by doing this, individual risk assessment is very important. So there's a baseline when we look at the different risks that our patients might come with. Any patient with a risk greater than 3 is known as a higher risk patient, and these people have to be thromboprophylactic. So what do we do when our patient is at risk? What do we do for such patients? So we first have to look for an ideal prophylactic agent, and the most important part of it all is that it should be effective. It should also be available. It should be accessible. It should also be relatively inexpensive. Also, it should require minimal or no monitoring. And Dr. Koko mentioned the different monitoring parameters that we can use for the different antithrombotics that we have on our market. And I'm very excited to present to you again and reintroduce Clexane to you. Again, I think we were here last year, so it's also a reminder to reintroduce Clexane to you. We are still available. We are accessible as well, available in the different hospitals. And also the fun fact is that we have reduced our pricing so much that for some places who take products from the medical stores, they can benefit from it because it's on the NHIS as well. And for Clexane, I think when Doc was talking about the cycle, we also and it works by binding to antithrombin, and its effect is mainly by inhibition of factor 10A. So it has been on our market for over 3 decades and has very much of a good track record after Clexane. So when we look at Clexane, we can say that our patients will get the efficacy that they need in patients with hip replacement surgeries, in patients who have unstable angina, also in treatment of acute ST elevated MI, which Doc also mentioned, Clexane can be used as well. Also in the treatment of DVTs and also PEs, also can be used in the prophylaxis against DVT and PEs. So the dosing for Clexane is very simple. For our patients who weigh less than 50 kg, or those who weigh 50 kg will take 20 milligrams as prophylaxis. So it is very common that we see a lot of 40 milligram or 4,000 IV prescriptions. However, we want to state again that it's the weight dosing. Like we look at the weight, the weight-based dosing. So for patients who weigh between 51 and 90 kg, they will benefit from the 4,000 IU or 40 milligram as prophylaxis. Also, we have patients who are between 91 and 130 kg, 6,000 IU or 60 milligram. Patients between 131 and 170 kg, 8,000 IU or 80 milligram. Then those above 170 kg would be a 0.6 milligram per kilogram body weight in terms of dosing. For treatment, we use a 1 milligram per kilogram body weight BD or 1.5 milligram per kilogram body weight daily. And for Clexane, we have different strengths of it. And also for renal impairment, the dose has to be reduced. So let's say you have a patient who requires Clexane. The dose can be reduced to a 20 milligram once daily for patients whose creatinine clearance is less than 30 ml per minute. And also, when it comes to treatment, these patients' dose will be reduced by giving them just 1 milligram per kilogram body weight daily instead of BP or 1.5 milligram per kilogram body weight daily. So for renal impairment, it's 1 milligram per kilogram body weight or the 20 milligram as prophylaxis. And as such, our patients can be on Clexane, and also we should ensure that we are monitoring such patients as well. This is the different strengths that we have of Clexane. We have 20, 40, 60, 80. We have all available. We do not have only the 40. We have all these strengths available, and we are looking out for these for some of your patients who require higher strength. Kindly note that we have it available. And of late, we've been having a lot of generics and also copies on our market. So for Clexane, it's a biological molecule and stringent processes are taken through to ensure that we have a drug that is very effective and a drug that can help your patients without activating any viruses in your patient. And that's what we are guaranteeing with the use of Clexane. And also, when we check from data, you cannot compare the two. You cannot say that generic is the same as Clexane in any way. This is because studies have shown that it is more potent, there's slower clot formation with the use of Clexane as compared to the copies, and also it shows that there's a sustained anticoagulation effect with the use of Clexane as compared to copies. So let's note that we cannot switch between Clexane and the copies. You cannot choose the copies of Clexane. Clexane is superior. And this is the product of Clexane. The injection technique is very simple as well, subcutaneous. And to end our presentation, we'd like to say that in prophylaxis against venous thromboembolism and also in DVT, now medically ill patients, let's ensure that all our patients who will be on our ward for more than 48 hours are being risk assessed and also are being given the prophylaxis daily. Thank you very much.
Thank you very much. I'm watching. I think, Dr. Foucault, you have to take your speak from them. Any statement, as Doc said, so please make sure that you take your fee from them. I'm going to take just a few questions, then we are off to our cocktail. That cocktail. So those who are anticipating it, we are just moving, the card is ready. But just a few questions. So online questions. So somebody is saying that at the primary care setting, sometimes picking up this thromboembolic, venous thromboembolic can be dicey. And if you can quickly take us through steps very well, especially when it's not very clear. The environment not like where Dr. Fuko works. You might not have some of the things that will help you be able to diagnose it as PA may not be available. So that one is coming to you. Just a quick one.
Remember that there are two sides of the coin. So there's a DBT and the stigma. So with a DBT, like I showed, the picture I showed, and someone can maybe asymptomatic, just by history, suspect that the person had a DBT, evaluate, or the person may come with legs swelling, pain, and then some reddening, lateral legs swelling. You may think it's a cellulitis, but you may need to go further and evaluate. Clinically, apart from the circumference, measuring the circumference, and then the rest in the history, bed rest, so that's where your wealth criteria also comes from, risk stratification also comes. Bed rest, surgery, some malignancy, some trauma, etc. That will trigger, or like say, a response. So once you suspect, you do your well scoring, the modified well scoring. The other filters will be scoring, and then you, if you do have a D-dimer as a testing facility, so it also has to be specific. It has to be an enzyme type, because there are different factors that can confound the D-dimer results. So it has to be that. And once you can do the D-dimer, if it's negative, then you know that there's no way there's any plot. So then you can decide not to, so that's what we do, not to go further. If it's positive, then you go ahead and do a compression of the what we call the double. There's a plot, and then you treat. If already the suspicion is very high, you person has all the signs, then you go straight to you may skip the internal test already. For VT, so depends. If a person comes in with sometimes shock and you evaluated, you ruled out other hemorrhagic causes, hypovolemic issues, cardiac, and you think that it is likely to be a P, you also do your risk. You are allowed to start your evaluation or your resuscitation while you confirm. Now to confirm, you need to do your echo. Sometimes you may not, the person may not be that able to move and the CPA, or because the person is not so stable, you can't do even if you have it. So you may want to do an echocardiogram with the right heart, do an X-ray, do an ECG, of course. So you sort of gather the evidence that is available. It may help you chest X-ray or exclude other information. Then there are other biochemical labs that we need to do baseline, liver function, etc. But then, because of the fact that you may not be able to tell if this is a batch, you already probably have done a proposition, you do them, you do your D-dimers. So I don't know whether I'm answering the question.
No, I think that you have, but I just want to tell others that we should also share the light some of these things you may have to, take note of the steps for and apply, some of the steps. But for go,
If you can do a CTP and the product, go ahead and do it, and the person is stable, you go ahead and do that. Different things.
thank you very much, Dora. Dr. Doctor, a lot of people are asking questions on why. First of all, they're saying that why is one contraindicated in individuals with mental health? Someone said that, can you please repeat the antidote for the one? Said that name was big and they've not heard of it before. Another person is saying that, can you combine cleansing, heparin, and aspirin when you're managing DVT? Wow. Combine cleansing, heparin, and aspirin with DVT. So,
And combine DBT, right? DBT, what we tend to do. Time find some place. That's where you find it. One, first, DBT.
can you take the mic to your mouth? Our 500 members online.
With DBT, it's either the low mutual right? Or what?
And then the question of the what? So, why is it contraindicated?
I told you the
Study.
the watch study, WhatsApp study, where one has been everybody might have a lot of issues, crash and crashing, need to be going to the hospital, while to check whether you are in therapeutic range or not. It's a bit discomfort. People want easy things. So when the class people board, some people start that the best to see whether they can help us. But the mechanical bus was work that has been used all the time and to get a lot of great results, provided they are within the therapeutic. So we started, who has said about the place, what study, then the realign, they put the people on warfare towards, and they realized that people were put towards. They rather have the opposite effect, having completely bleeding compared to anytime a study is being done. What they do is that they bring the new champion or the supposed new champion, bring the good. This time, the supposed new champion that is brought into the world was not able to defeat the old champion. So they realize that the person has to stay on. Now, as time goes on, now there are new studies that are going on. But now, because of the realignment, then again, there are also two versions of valves that are being used. There's a valve that one doesn't require any equipment. The first we can use is aspirin. Some people know for honest protect valve. There are new valves that is less to the valve. In Ghana, I remember the one case, 50 years, where they did that.
The last one, we're asking for the repeat of the article for the part. Repeat of the article.
The number and then the number is out. And the other one, I find it.
Please,
And
the consultant is to give it. Please refer to
the two up here is anticipate out. And then the one for the department at the Zoom.
you. Please, take Tresiba. What's the cost? But that's the question. Maybe you were talking about 5 minutes. What is the cost of Tresiba?
Okay, thank you. So Tresiba is actually 208. Hello? Okay, so Tresiba is actually 286. That is the cost coming from our distributors, both locals. That is the cost of Tresiba coming from both locals and worldwide. Now, what will happen is it will vary from one hospital to the other, one pharmacy to the other. However, we encourage healthcare practitioners to always push their patients to buy from the hospital because it will always be cheaper at the hospital.
Thank you very much. Thank you very much, Novo. And to start off, if someone is asking, what is your opinion, recommendation on the use of Flexane post-cesarean section? Indicated in your trial and other things indicated as well. If there are any questions out there, taking 2 questions, can raise up your hand. Dr. Adrian will come to you.
Thank you very much. So, post-cesarean session, Flexane is being used. And I think for our clinical trials, we know within the space of pregnancy and also children, we do not do clinical trials within these patients. So it hasn't been done. However, according to our guidelines that we use in the country, it is recommended at least 6 hours post-cesarean session. Thank you.
Thank you very much. Any question here? Or all questions have been answered? If you have any question, before we move to the plan for our mega cocktail. Okay, it looks like our specialists have done a good job. And everybody here, very good with what has gone on. Just to say again that the slides we shared, you can access it and go through it again. I want to say a very big thank you to Dr. Foster for he has come all the way from Accra to be with us. Really appreciate it. Dr. Abdullah. This time I'll just say my sister. Thank you very much for your presentation. Our sponsors, we have Sanofi here, we have Novo here, we have Koringa, they've been helping us throughout. They are here as well. I think I didn't mention Trident, they are also one of our sponsors. And to all our sponsors, we really appreciate it. Zipla, AstraZeneca, Novartis, Mega, Salina. I think I've not left any now. We really appreciate the partnership that we've had over the period, and we hope that the partnership will continue even as we try to impact. Thank you very much. The buses are ready to the mega cocktail. The family, the commander doctor, African family are hosting us for gratitude. It's going to be a wonderful time together, wonderful time of interaction. This is the time that we are going to, those from all over the country, from the northern, middle, southern sector, this is the time to interact and for ourselves. All the time we sit here, we go to our room. But this time, we are having our supper and dinner, everything that you can call it, top it up by a cocktail at Kokrantune buses are ready. Let's quickly join in and let's enjoy ourselves. Thank you very much. Our online viewers really appreciate you. We had over 700 people joining us both on Zoom and on YouTube. We really appreciate you. Thank you very much. Stay blessed. Have a nice evening. Tomorrow we are here at 9 o'clock to start our scientific section. Tomorrow, 9 o'clock, we are here. Repeating again, tomorrow 9 o'clock, we are starting our scientific section. Thank you very much.
Still good, Charles. Still good, check on it.